My name is Rakesh Suri. I'm a professor of surgery in the Division of Cardiovascular Surgery at Mayo Clinic. My interest is in valvular heart disease, mitral valve repair, and specifically robotic mitral valve repair. The title of our manuscript is Improving Affordability Through Innovation in the Surgical Treatment of Mitral Valve Disease. This will be published in Mayo Clinic Proceedings. There is one effective therapy for degenerative mitral regurgitation. In other words, once patients have severe MR, medical management or watchful waiting have been proven not to be effective. Surgical treatment, ideally mitral valve repair, is the guideline-based standard of care. Patients are often hesitant to accept early mitral valve repair because they're asymptomatic and they don't understand the need for a sternal splitting operation when indeed they don't have symptoms. The literature in the last decade has really shown us that once patients have severe regurgitation, they need to undergo surgery as soon as is convenient. And that usually is mitral valve repair. Mitral valve repair is capable of restoring patient survival to normal with very low surgical risk and is a very durable operation. The problem with mitral valve repair to date is that patients have been hesitant to accept the need for an early operation, and cardiologists and referring providers have been more reluctant to refer patients for operations that require sternal bone splitting. On the other hand, minimally invasive operations over the last decade have greatly improved, both in their safety and efficacy. Robotic mitral valve repair is such an operation. We know that robotic mitral valve repair can be performed with near certainty, in other words, greater than 90 to 95% of the time, with very low surgical risk, approximately less than 0.3% risk of death, and it's a very durable operation when performed by referent heart valve teams at high-volume mitral valve repair centers. What's unclear about new technology such as robotics is whether it's cost-effective. In the current healthcare environment, we're called upon to justify the need for more expensive, high-technology equipment to perform the same job as could have been accomplished through more conventional approaches. The same is true of mitral valve surgery. Open mitral valve repair is safe, durable, and associated with a predictable course of recovery. Robotic mitral valve repair is performed in exactly the same way, is safe and effective, but hastens recovery for all categories of leaflet prolapse. We sought to understand the cost differential between patients undergoing open and robotic mitral valve repair. We examined 185 pairs of patients undergoing either robotic or open mitral valve repair who were closely risk matched. We sought to determine whether systems innovation, i.e. making things go more efficiently in the operating room and on the floor, and getting patients out of hospital more quickly, could impact the cost of care overall in mitral valve disease. Additionally, we were interested in determining whether technically innovative approaches such as robotic mitral valve repair performed in conjunction with systems innovation could impact the total cost of delivering care in mitral valve disease and mitral valve regurgitation. The findings of our study were similar to those published previously. In other words, patients undergoing robotic mitral valve repair had safe and effective operations. The repair rate was 100%, and patients were routinely dismissed from hospital on the third day following surgery. Moreover, there were no deaths in either the robotic or open surgical group. Patients undergoing robotic mitral valve repair were extubated more frequently on the operating room table, were transitioned through the intensive care unit on the same day of surgery and out to the floor-based care the same day. Following the initiation of systems innovations in approximately July 2009, we found significant changes in the robotic group. We examined clinical outcomes and cost of stay both before the implementation of systems innovation in July 2009 and following it. Whereas the cost of robotic mitral valve repair operations soon after initiation of the program were slightly higher in comparison to conventional open mitral valve repair operations, costs decreased steadily and significantly with time. Once patients are found to have severe degenerative mitral regurgitation, confirmed echocardiographically, they should be referred to a referent mitral valve repair center where surgical expertise exists in mitral valve repair. Once patients are seen in mitral valve repair centers, the pros and cons of either watchful waiting or surgical intervention should be presented, including repair rates, perioperative risk, and surgical platforms available. Where appropriate surgical volume and expertise exists in mitral valve repair, minimally invasive mitral valve repair programs have evolved. What is important in such programs is that mitral valve repair be performed in exactly the same technical manner as it would in a standard open mitral valve operation. In other words, the components of a mitral valve repair, the cutting, the sewing, the annuloplasty, and the neocord placement are all identical to those performed in a standard conventional transsternotomy mitral valve repair operation. Also important to clinicians is that patients be referred to centers where results are available. In other words, patients should be offered operations that are very low risk, less than 0.5%, with a high certainty of mitral valve repair, approximately 95 to 99%, and excellent durability, a rate of reoperation following mitral valve repair of approximately 1% per year or less. If you're told you have severe mitral regurgitation, ask to be referred to a center and to a surgeon specializing in mitral valve repair. Meet with the surgeon, understand risks, benefits, surgical outcomes, and available opportunities, including less invasive approaches. Less invasive approaches, broadly speaking, can include keyhole or small incision mitral valve repair through the right chest, thoracoscopic mitral valve repair involving use of long instruments and cameras with the surgeon standing at the patient's bedside, or robotic mitral valve repair, typically a two-surgeon operation with one surgeon at the patient's bedside and a second surgeon at the robotic console. The risks and benefits and appropriateness of each of these platforms for you will be determined following a thorough history and physical and appropriate preoperative testing, including a CAT scan of the chest, abdomen, and pelvis. So there are really three take-home messages. As healthcare costs continue to increase and we're all charged with introducing new technologies but decreasing the economic footprint of what we do, the marriage of systems and technical innovations have an important role to play. Systems innovations can decrease costs, and that's true whether it's open valve repair surgery or new approaches such as technically innovative robotic mitral valve repair. Second, technically innovative approaches can be introduced in a cost-neutral manner with the use of systems innovation. And third, the marriage of systems and technical innovation not only benefit patients by decreasing the length of hospital stay and returning patients to their normal life and employment-based activities more rapidly, but it decreases our economic footprint on the healthcare system.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.com. This video content is copyrighted by Mayo Foundation for Medical Education and Research.